We looked at the results of a specimen stain to list the most likely organisms present in the specimen. We described the basic process of microbiology testing for identification and susceptibility, and we identified the normal human flora and the role in infectious diseases. Now, let's explain the antimicrobial stewardship process for initiating, monitoring, and streamlining effective and safe antimicrobial therapy. The first thing to do in a systematic approach to infectious diseases is to start with the question, what are we treating? And there are 4 questions to ask. First, did you determine the infection site or type using subjective and objective patient information? That includes signs and symptoms that are specific to an infection type, or it could be general manifestations of infections. Second, did you assess severity using SIRS or an infection-specific tool to determine where the patient should receive care? As we learn about different infections throughout this course, we will talk about infection-specific tools that are relevant. Determining the severity of disease can help triage the patient to the appropriate setting in order to receive appropriate care. And in general, we can think of the settings as outpatient or inpatient. So someone who is less severely ill and is ambulatory, meaning that the patient is able to walk, so the infection is not severe enough to prevent them from walking, this patient can make appointments at the clinic, make appointment with the primary care physicians, or in an ambulatory care clinic with a pharmacist in order to receive care. Now, slightly more urgent would be if the patient is still ambulatory but needs urgent treatment. So that for that reason, the patient can go to an urgent care. And then we have emergency departments. And this is kind of an overlap between outpatient and inpatient, because when people go to the emergency department, they do not necessarily get admitted to the hospital. So a lot of patients who go to the emergency department may actually get treatment and get discharged home. So they may go home with a prescription. So they will go to the pharmacy, either the outpatient pharmacy at the hospital or perhaps to the community pharmacy to receive medication, but may not necessarily require admission to the hospital. And on the other hand, some patients may be sick enough at the emergency department that would require admission to the hospital. So once that's determined that a patient needs to be admitted to the hospital, they will be sent to the general ward on the floors of the hospital. And that is where patients will receive care inside the hospital. And in severe cases, in critically ill patients, they may receive more specialized care inside the intensive care unit. So patients may actually need to go to the ICU. So that would be the most severe disease. Now, the third thing to consider is, did we obtain cultures from the infection site before starting antimicrobial agents and remove the infection source? So source control is important, because if the source of an infection is still there, doesn't matter how much antimicrobial agents you give to the patient, the infection continues to come back. So source control is important. And the reason you want to get cultures before giving antibiotics, because even a single dose of antimicrobial can pretty much eliminate organisms from the specimen, so it would be difficult for us to grow it in the culture. Even though a single dose may not necessarily treat the infection, but it would reduce the inoculum in the specimen enough that it will be difficult to have a good yield out of the specimen. And fourth, did you list the causative pathogens from most to least likely? And this is, initially, before we actually identify what's growing in the specimen, it's a guessing game. So we have to, based on the signs and symptoms and the infection, we have to guess what's the most likely pathogen so that we can target those pathogens empirically before we actually find out what's causing the infection. Now, the second thing to consider is, how can we ensure that the patient receives the most effective therapy? So let's focus on efficacy before we move on to safety. Of course, the first thing we want to do when possible is to make sure that we use reliable resources to select non-pharmacologic therapy. Then we consider reliable resources to select the antimicrobial regimen of choice. So in general, for most infections, we have first-line therapy and we have alternative therapy. So when the patient can get first therapy, that would be the best approach. And occasionally, the patient may not be able to get first-line therapy for various reasons that we will discuss, and that's when we can go to alternative therapy. And the next thing to consider, if more than one option is listed, did you use an antibiogram or another reliable source to select a regimen with activity against a high percent of likely causative pathogens listed in checklist item number 4. And here's what an antibiogram looks like. So here's an example of the antibiogram from Loma Linda University Medical Center. So here you can see that each row is a different organism. So for example, the first line of organisms is Acinetobacter baumannii. And then this, in the second column, they're showing you the number of isolates. So isolate means, pretty much how many times this organism was growing inside the microbiology laboratory. So for example, if we had, and these are unique to a patient. So in other words, if we sent 2 blood samples from the same patient and E. coli grew in both, that counts as one isolate. Okay, so if you had multiple patients, so it essentially tells you over the time period that this antibiogram is reporting. During that time period, this organism was isolated in the lab 53 times. And then there's reporting you their susceptibility, the percentage susceptible to each antibiotic. So if there is a dash, that means they just did not test against that antibiotic because they're not routinely tested. So it's reported for things that are routinely tested. So for example, ceftriaxone. So when they checked susceptibility of Acinetobacter to ceftriaxone, it was susceptible 17% of the time. So that's pretty bad. Only 17% of the isolates were susceptible to ceftriaxone, whereas when you compare that to meropenem, that's slightly better. So that's 30% of the time. And if you look across, these numbers look pretty bad because this organism is highly resistant to most antimicrobial agents. So that's why these numbers look pretty bad. Now, if you look at another organism such as Citrobacter frundii, there were 31 isolates during this time period at the micro lab. 35% of these were susceptible to ampicillin. And let's say 100% of them were susceptible to imipenem and meropenem, and 81% were susceptible to trimsulfa. Okay, so you can do the math. So this is reporting susceptibility. So let's say if 97% of Citrobacter frundii was susceptible to gentamicin, for example, that means the remaining 3% was not susceptible. So if you want to identify resistance, you basically subtract this from 100. So for amikacin, for example, the resistance rate was 0% because 100% were susceptible to amikacin. So that's how it's reported. And for some organisms, there also report a subclass of those. So for example, E. coli, we'll talk about what ESBL means on another lecture, but some E. coli produce something called ESBL. So they're showing you that for those isolates specifically, what the susceptibility look like. And another good example is Staphylococcus aureus. In general, we like to classify Staph aureus either as MSSA or MRSA. And essentially, in the line with Staph aureus is showing you all of the isolates of Staphylococcus aureus, regardless of whether it's MSSA or MRSA. And then the next line includes MSSA only. And the next one is MRSA only, and then they show you susceptibility. So that's how an antibiogram looks like. And in general, for most times, you want numbers that are at least 80% susceptible and higher. So that would be pretty good. So these numbers under 80% are pretty bad. So So, if you have options, you want 80% or higher. In the ICU, when patients are critically ill, you really want 90% or higher for most infections. So that's something to keep in mind. And now you have to take that with a grain of salt. So it doesn't mean that you should only use the highest numbers. We'll talk about how to choose, because this is only one factor when we select antimicrobial agents. So once you have 80% or higher, that's good enough for most infections. You don't necessarily want to start with 100%, and we'll talk about that more on a future lecture. Now, the next thing to consider is, did you consider the active antimicrobial agents with the narrowest spectrum, the drug of choice? So in general, we want to avoid a broad spectrum and focus on narrowest spectrum possible, and we'll talk about that on a later lecture. And penetration is also important. So depending on the type of infection you're treating, you want to make sure that the antimicrobial agent actually penetrates to the site. And here's what it means. So essentially, in general, we either take antimicrobials orally, so it goes in through the mouth and then it's absorbed and goes into circulation, or it's directly injected into the blood. And there are other routes, but in general, we'll focus on intravenous and oral routes in this course. And if your infection is, for example, meningitis, you really want to make sure that antimicrobial agents you use actually penetrates into the site of infection. So it's important to know, what percentage of the drug from the blood actually goes through the cerebrospinal fluid, or CSF. So that would be significant for meningitis. If you're treating a urinary tract infection like cystitis, you want to make sure that the drug actually goes to the urine. So for example, if a drug is not renally cleared, it's not going to go to the urine. So even though you get a large concentration of the drug in the blood, it's not going to go to the urine. So you want to make sure you choose something that goes into the urine. And so on and so forth. So for skin and soft tissue infection, you want to make sure it penetrates the skin. For bone infections, which we call osteomyelitis, you want to make sure you get bone penetration. For peritonitis, which is in the peritoneum or peritoneal space, you want to make sure that the drug penetrates that area. Occasionally, if the infection is inside the intestines, for example, Clostridioides difficile colitis, you actually want to make sure that the drug stays in the stomach and is not absorbed into the blood. Or if you're injecting into the blood, you want to make sure that it can actually go into the intestine. Otherwise, it's not going to get to the site of infection. And for pneumonia, which is infection of the lungs, you want to make sure there is penetration into the lungs and epithelial lining fluid. So penetration is important. And for severely ill patients, you want to make sure that you consider using IV antimicrobials empirically, when appropriate. So in general, people who are severely ill, they may not have, for example, if you give them orally, they may not absorb it quickly. Or patients are sick, so they may be vomiting, so you don't want them to vomit the antibiotics out. So IV in general is initially appropriate, and of course within reason. So again, if you're treating C. diff colitis, you want to make sure that an oral route might be a better choice because the infection is inside the intestine. So you have to use these things cautiously. But in general, for most infections, IV is initially appropriate for severely ill patients. And the third thing we want to consider is we want to make sure that it's what we're giving the patient is safe. So for patients with drug allergies, you want to avoid selecting antimicrobial agents that may cause allergic reactions. If a patient is pregnant or of childbearing age, you want to avoid teratogenic agents. You want to evaluate if a patient is at high risk for adverse effects, or if there is contraindications, you want to avoid those in the patient. You always want to check for drug-drug interactions if the patient is taking other medications or over-the-counter agents, including herbals, supplements, etc. For immunocompromised and those with meningitis or endocarditis infections, we want to consider in general bactericidal antimicrobials. Now this is a bit controversial because the evidence for this is not clear, so it's not studied well. But in theory, we think that bactericidal may benefit patients who are immunocompromised or have meningitis or endocarditis. And here's what that means. So essentially, the definition of bacteriostatic means that the agent prevents the growth of bacteria, whereas bactericidal means that it actually kills bacteria. So let's look at this graph, the graph in the middle on bacteriostatic. So here on the x-axis, we're looking at time, so 2 hours, 4 hours, 6 hours, and 8 hours. And on the y-axis, we are looking at cell density measured in colony-forming units, or CFU. So the first line you see is essentially the control, meaning that we have a certain bacteria, and assuming that the conditions are correct for growth, meaning there is food for the bacteria to consume and the temperature and all the conditions of the environment are correct for growth, if you leave it alone, it will grow over time, right? So 2 hours later, 4 hours later, the number of colonies will increase. And if you give antibiotics, it will essentially prevent the growth. So what bacteriostatic means, and some examples include tetracycline, erythromycin, and linezolid. If you give any of these bacteriostatic agents, it will essentially prevent the growth. Okay, so it's essentially preventing the growth. Now on the right-hand side, the same thing is done with bactericidal agents. So you can see again the control line. So if you leave it alone, the colony-forming units will increase over time. Now these are bactericidal, that they actually mean that they will drop the number of colonies. So it's not just a flat line. They actually decrease the number of colony forming units over time, and some of them more rapidly than others. So for example, aminoglycosides such as gentamicin are famous for rapidly dropping the number of colony forming units. So it actually kills pretty fast. And some of them kill slower. And these are all experimental in vitro. So this is not necessarily inside a patient's body, but inside a test tube where these experiments have been conducted. So the theory is that if somebody is immunocompromised and they don't have the benefit of immune system, this might be dangerous to just prevent the growth because there is no immune system to actually kill it. So you want to rely on bactericidal to kill as many of these before the bacteria kill the patient. Now, this has come under scrutiny because a systematic review of many studies actually found that for the large portion, there is no clinical difference between bacteriostatic and bactericidal agents. So in general, it doesn't matter. However, the studies, there are not good studies looking at this specifically in immunocompromised patients like transplant patients or those with endocarditis and meningitis. So some of these are based on case reports that have shown there may be benefits to bactericidal. So it's a bit controversial. In general, doesn't matter if it's bactericidal or bacteriostatic unless you're dealing with immunocompromised meningitis or endocarditis. And the next thing to consider is, if you have multiple options, you want to choose the most affordable option for the patient. Now, the fourth thing to consider is how can we ensure the patient receives the right dose? So you want to optimize the dose of antimicrobial, and this is important for us as pharmacists. So in general, you may consider a loading dose, if it applies to the antimicrobial agent, and you want to make sure that you use appropriate body weight. So sometimes some agents are dosed based on ideal body weight, sometimes adjusted body weight, and sometimes total body weight. So you want to make sure you are using the correct weight when calculating the dose. And sometimes you need dose adjustments. So depending on renal function and liver function, you may need to adjust the dose based on that. And in severely ill patients, or any time that you have MIC data available, you want to optimize PK/PD. And I'll talk about what that means in a minute. For outpatients, you want to make sure you increase adherence. So in general, it's hard to improve adherence if you give the drug more than twice a day. Ideally, once a day is best for adherence, but twice a day sometimes is difficult to avoid. But anytime you have the option between twice a day and 3 times a day, or worse, 4 times a day, you really want to do twice daily to improve adherence. And of course, always think about duration of therapy. And in general, shorter the duration of therapy, the better, because of adverse effects and unintended consequences of antimicrobial agents. So you want to choose the shortest duration of therapy that's proven to be effective. Now here's PK/PD. So pharmacokinetics in general means what the body does to the drug. So in general, you can think of, once you start giving the drug, the concentration keeps going up. And then once you stop giving the drug, and whether it was oral, so this was oral absorption, or if you were giving it intravenously, this is when you stop infusion, then you have a drop in the concentration. So the body starts eliminating from the body. So that's pharmacokinetics. And pharmacodynamics is about what the drug does to the body. So essentially you measure the effect. So initially there is no effect. As the drug enters the body, you start to see the effect. And at some point there is like a ceiling effect. There's only so much effect you can give, right? That's in general. When it comes to antimicrobial agents for infectious diseases, we like to combine pharmacokinetics and pharmacodynamics because they can only make sense together. So the way we think of pharmacodynamics is that we need to consider MIC, and MIC is the minimum inhibitory concentration of the drug. And there are some PK/PD parameters, such as the ratio of maximum concentration to MIC, or the ratio of area under the concentration curve to MIC, or the time that the concentration is above the MIC. And we'll talk about those on a future lecture of when to use each of those and what they mean. But these are essentially the PK/PD parameters we use. And the reason I am emphasizing this is that there is a lot of variation or variability between patients. So there is inter-individual variability. So you can think of age. There is a difference in pharmacokinetics between a young adult and an older adult. Sometimes race and ethnicity can make a difference. Obesity can affect pharmacokinetics, comorbidities, medications, and there are also intra-individual variability. So depending on what's going on, sometimes there is altered fluid balance. If you're giving a lot of fluids to the patient, that can change pharmacokinetics. If there is renal or hepatic dysfunction, or if there is organ support. I'll talk about some of these in a minute. And then pharmacodynamic factors are things such as host immune response. So sometimes patients might be immunocompromised. Inoculum size. So sometimes, an infection can have a lot of bacteria at the site of infection. That's referred to as the inoculum size. Or sometimes there might be just a few. So the higher the inoculum size, the more difficult it is to eradicate the bacteria from the site of infection. We talked about tissue penetration at the site of infection. There are things like biofilm that we'll talk about on another lecture. And there are other things that affect pharmacodynamics. Now, when it comes to critically ill patients specifically, there are important things to consider. So for example, there are 3 things I have listed on the left-hand side that can lead to reduced plasma concentrations. So for example, hyperdynamic environment in the patient. So whether naturally if the body is responding to let's say a drop in blood pressure due to the infection, or whether we are actually causing this by giving pharmacologic agents such as vasopressors. If the cardiac output is increased, because we want to bring the blood pressure back to normal, so the patient doesn't go into shock, or the patient is already in shock and we're trying to bring them out of shock, that can increase perfusion to other organs such as the kidneys, and can lead to increased elimination of the drug, so your plasma concentrations may be lower. So this is something to consider, which means that in the ICU, you may need higher doses of the drugs. Another thing is alter fluid balance. So again, if you're giving a lot of fluids to the patients, it keeps diluting the concentration of our antimicrobial agents. So we may need to increase the dose. Sometimes there is third spacing. So if the fluids keep going into, let's say, peritoneal space or in other third spaces, the drugs can get diluted, and so plasma concentration will be lower. The same with protein binding. So if you have drugs, for example, ceftriaxone is highly protein bound. So if there is altered protein binding, so for example, if the patient's albumin is less than 2.5, then there isn't enough albumin around to hold on to ceftriaxone, which means that unbound ceftriaxone will be eliminated from the body, so you'll have reduced plasma concentration, which means that you may need to increase the dose. And there's also the phenomenon of augmented renal clearance. This is specifically defined as creatinine clearance greater than 130. So in other words, normally pharmacies dose adjust based on renal dysfunction, right? So if the creatinine clearance, let's say, is less than 60 or less than 30, depending on the agent, we like to reduce the dose. This is the opposite. So augmented renal clearance essentially means the kidneys are working too well, so it's clearing the drug too much. So you actually need to dose adjust in the other direction. So you need to increase the dose because of reduced plasma concentration. And things that can lead to augmented renal clearance include things like trauma, sepsis, burns, hematologic malignancy, or pancreatitis. These are some of the risk factors, and this is more common inside the ICU. And of course, it's possible that the patient may have no organ dysfunction and be critically ill, which means that your plasma concentration are actually normal. And then on the other end of the spectrum, we have if you have increased plasma concentration. So either because of renal or hepatic dysfunction, so the drug is not getting cleared. So your plasma concentration go higher, so you need to dose adjust and reduce the dose. And sometimes there is organ support. So if there is renal replacement therapy or ECMO, you may have increased or decreased plasma concentration. For example, if someone is on renal replacement therapy, essentially the kidneys are not working, so you may have increased plasma concentration. And then also depends on the settings of the dialysis and whether it's how well it's clearing the drug. So you may have increased or decreased plasma concentration. And then things like ECMO can increase volume of distribution, and sometimes the drugs can get attached to the equipment. So it can lead to reduced plasma concentration. And here's what ECMO looks like. So ECMO is essentially kind of, what dialysis is to the kidneys, ECMO is to the lungs. So dialysis, essentially the kidneys cannot work. So dialysis takes over the kidneys and it adjusts, toxin, it removes toxins from the blood, and it balances fluids and electrolytes, among other things. What ECMO does is if the lungs don't work and cannot oxygenate the blood, so essentially the blood will go into this machine. The machine will exchange gas. It will exchange oxygen for CO2. So it puts oxygen into the blood and removes CO2 from the blood, and then this goes back through the pump into the body. So this is a big machine, and as you can imagine, the blood is going through this big machine, so volume of distribution changes, but ultimately drugs can also get stuck in this machine, so that will affect your drug levels or concentrations. And the best thing to do is to do therapeutic drug monitoring to actually when available, because we cannot do therapeutic drug monitoring for every drug. But when available, the best thing to do is to actually measure plasma concentration and see if it's decreased or increased, and make adjustments based on that. For example, a good example is vancomycin, where we can get plasma concentrations, and based on the level, we decide whether we should increase the dose or decrease the dose or leave it untouched. The last thing that we should consider is how can we ensure this works and does not happen again. So we do want to specify how and how often we'll monitor for efficacy and safety. If cultures and susceptibility results have returned, you do want to go back to number 8 and start from number 8 in order to optimize the dose and regimen. And did you recommend immunizations and other preventive measures? So that's important. And lastly, as pharmacists, you do want to provide counseling, not just about the antimicrobial agents, but also about the infection. So what to expect from the infection, how often, what to look for, and what to expect as far as resolution of signs and symptoms, and of course, what to expect of antimicrobial agents, adverse effect profile, how to take it, with food, with water, without food, or and how long to take this. This concludes this presentation.